Dave Tuvison from the Cancer Research UK, Cambridge. Research Institute is next. Going to talk about pancreatic cancer.
I want to thank Patty and the organizers for the kind invitation to cross the Irish Sea. So we just came from lunch, and so this slide will be pertinent. And so in 2000, this movie came out of Hollywood with 3 Americans and 1 continental actor. What is a pancreas anyhow? I mean, I don't know what the damn thing does for you besides give you cancer. And of course, we just use our pancreas to balance our blood sugar and digest our food. But when it causes trouble, 250,000 people a year in the world die of ductal pancreas cancer. Our best surgeons can only operate on 10 to 20% of them. Only 5% of people diagnosed with pancreas cancer are still alive in 5 years. We have two drugs worldwide which are approved, Gemcitabine and Tarceva. The approval hasn't stretched yet to the UK and most of Europe for Tarceva. There's another drug coming along which probably will be approved soon. We have 4 signature genes. We've heard a bit about personalized cancer medicine, probably less of a problem in this disease. We have a driver oncogene. It's no mystery. Kirsten-Ras. P16, the RB pathway inhibitor, is mutated again in virtually all cases of pancreas cancer. P53, 3/4, SMAD4, half. So it's pretty homogeneous from a genetic standpoint. The Vogelstein paper, which came out in 2008, essentially confirmed that. The real problem when I see patients in the clinic, and those of you who share that experience with me, is our patients are sick when we meet them, and only half of them can get treated with anything. And so I don't know of a cancer like that, where half the patients diagnosed to get no treatment other than palliative, non-chemotherapy, non-oncological care. And then of the half that are left to get care, only a tiny fraction go on clinical trials. So that's the real problem in this disease, is that very few patients go on trials, and that's, of course, because the patients are feeling so lousy. They have intractable pain, they're losing weight rapidly, et cetera. So it's a bit of a problem, and so it takes, I think, new ideas and new folks to join the train to sort this out. The cartoon that we used in ductal pancreas cancer is shown here. It's similar to what you've seen already for colon, cervical, et cetera. The duct of the pancreas is histologically most similar to the invasive pancreas ductal adenocarcinoma cells shown there. Whether or not the duct of the pancreas is the cell of origin site or not is still a matter of debate and investigation in the laboratory. But nonetheless, we can find preneoplasms in all of our pancreases, which contain Kirsten-Ras mutations. But only 1 out of 100 of us who live to be 100 get pancreas cancer. And so again, this is a preneoplasm of uncertain significance, just like the moles on your skin, which you'll hear about from Rich Murray after me. So we all have this. Few of us have this problem, fortunately. Our job is to understand, why is this progression so slow? What are the events involved in it? Can we intervene? And of course, when we have our patients, can we do better than today? Some years ago, I decided to do a postdoc after I finished my clinical oncology fellowship with Dr. Chabner and other colleagues on the other side of Boston. And I decided to learn how to become a genetic engineer in mice. I worked with this fellow who at the time had no gray hair. This is Tyler Jacks, and we mutated a variety of genes in the embryonic stem cells of mice, akin to what you just heard about from Alan. We put point mutations into Kirsten-Ras as well as into P53. These were conditional. You can activate their expression by driving and directing Cre recombinase. So again, unlike Alan's, where you're knocking out genes, I'm knocking in genes, turning on genes. And so when we did this, we were able to derive a mouse model of early pancreas ductal neoplasia. Here's a PanIN 1A shown here with mucinous metaplasia in the duct. Here's the acinar tissue, have all the digestive enzymes. This is an islet where the endocrine component of the pancreas lies. Over a long period of time, this animal will develop this disease, an invasive adenocarcinoma of the pancreas. Most pathologists cannot tell histologically these pancreas tumors from those that our patients get. Importantly, our animals also get a syndrome of cancer where they're losing the muscles off of their back. They're developing abdominal ascites. They have metastases to all the relevant sites we see in our patients, to the liver, to the peritoneum, to the lungs, et cetera. When we include, in addition to RAS, one of these tumor suppressor genes shown below, you speed this process up, which is not surprising. We favor point mutation of p53 in heterozygous fashion, so the loss of the other allele is the first molecular event we see. And when we do that, we see that the mice which trickle along with their RAS mutation before they're dying in a year and a half are dying now in about 4.5, 5 months, such that you can use this as a tractable system in efforts to identify therapeutic approaches and diagnostic approaches for this disease. And over the brief bit of time we have together, I'm going to go over some of those types of experiments where we've used this model to try to find new therapies and develop also new diagnostics. One of the reasons why I got in the other version of the Mayflower and came over here was we couldn't do a particular experiment in America because of a patent called the OncoMouse patent. And that's a patent which has restricted a lot of the interesting therapeutic investigations using GEMs, genetically engineered mouse models of cancer. And so my smiling crew got in the boat and we came over here to actually ask questions with our pancreas ductal adenocarcinoma model in terms of interrogating various pathways. Ken, Mike, and Arthi, who have now moved on to greener pastures. As I said, the survival curve of the mice was shown here. It's a bit heterogeneous. You couldn't enroll mice on a time basis, which is what a lot of us do because it's easy. We had to figure out ways to identify mice which had a particular volume of disease growing at a particular rate in order to do therapeutic studies effectively. The way we did that was to develop a variety of imaging approaches, including ultrasound, which is the cheapest and fastest approach, using the proton chemical environment by MRI, shown here. If you infuse gadolinium, a paramagnetic substance, you get your so-called dynamic contrast enhanced MR, and this is the pancreas tumor, which you'll see in a second. And you can do the spinning mouse approach, where you're using nuclear agents such as FDG PET, which is fancy but expensive and useful for certain things. So one solution was to identify how to image the mice. The other solution was to actually put in place a professional team to do this work. So my lab has about 10 scientists and about 5 staff. The staff comprise of really a highly trained and sophisticated team who control my mouse colony, which is quite large, and enroll the mice on studies such that the postdocs and students fit into the projects and complete the projects. Each study costs about 150,000 units of currency, meaning a therapeutic that you're going to investigate very deeply. It takes about 3 to 4 months to do a study properly, so you're only looking at 3 to 4 drugs a year. So it is actually slow work that you dig into very deeply to try to get all the details. And the staff works all the time, and of course it still requires the academics to drive the inspiration behind the projects. So again, we palpate the mice for a long period of time, we detect a tumor, we image it, and when the tumor is a certain size, we enroll the mouse, and then we watch the experiment go. The first experiment was what we thought would be a control experiment. It took about 2.5 years to do the experiment. And this was just to treat the mice with gemcitabine, which again was the first approved drug for pancreas cancer. Hard to do that experiment in the States. The company that had the drug under patent at the time had absolutely no interest in understanding why this drug was so pathetically inactive in our patients. But the reality is when we looked at salt water compared to maximally tolerated dose gemcitabine in our model, there was very little difference in a mouse-to-mouse comparison of that cohort over a 12-day experiment, meaning all tumors doubled in size. So here it is at 100 MPK, here it is at 50. Here are some of the individual mice. We had 2 responding mice, which are interesting. One stabilized, one had partial shrinkage. And the interesting part, again, was this was totally opposite of all of the data which existed from the various transplant models which litter the literature and are what the FDA drinks like Kool-Aid in terms of determining what drugs work in our patients. Because the same group of people looked at xenografts, either orthotopic, subcutaneous, or syngeneic models, where you go mouse on mouse, so you can have the immune system still present. Did saltwater control versus gemcitabine. In blue, everything's doubling, trebling, or larger. In red, you have cytostasis in every model that we've looked at. And again, here's the data you already saw. So a total disconnect, a binary difference. You don't need a supercomputer to actually analyze that anymore. We did pharmacology on these tumors and those, looking for gem triphosphate, which is the active moiety of gemcitabine. It gets incorporated. It gets into cells through the equilibrative nucleotide transporter. It gets phosphorylated 3 times to become a toxin inside cells, where it interacts with a variety of cellular proteins and occasionally gets incorporated in nucleic acids. You could measure gemtriphosphate in these tumors, but not those. So that was our first observation, that something was really amiss. And then we did a lot of other studies to confirm and sort out what was exactly going on. So this is an H&E of these primary tumors in the mouse. So here's the tumor, here's the small bowel and the pancreas. And as you see, there's some white swirls here. The white swirls are the stroma of pancreas tumors. And if you're a medical oncologist, you may not remember from pathology what these things look like, but if you're a surgeon or a pathologist, you remember pancreas tumors are white, rock hard. They're very different from the squishy red tumors that exist in many other carcinoma types. And so here's a primary pancreas tumor in the mouse, looks similar to the human. Here's a transplant tumor, in this case under the skin, but orthotopic look very similar. It's pink because it's full of cells. Doesn't have a lot of extracellular matrix, etc. Now these images here, which the folks behind me are trying to make it so you can see, you still can't see them. I don't know if it's because your computer doesn't like my program or it looks pretty good here. How about just like kill the lights so that, just kill these. Make the blue and stuff go away. I want you to see this because this tumor here is blue. All you see is DAPI. You don't see a fluorophore getting into the tumor. This one is all green because the small molecule gets in. The small molecule used is adriamycin. And just as another way of showing you that there was a real problem with perfusion. Under the microscope, again, you can look at the structure of human, mouse, primary pancreas cancer, look at all your transplanted models. And if you just look first at the stroma using Mason's trichrome, transplanted models have very little stroma, as shown by the fibers here, compared to primary mouse or human. And in the stroma lie the blood vessels, which is true in normal tissue and true in diseased tissue. And so the vessels are very abundant in these transplanted models and very deficient in primary mouse pancreas cancer and human. And there's a distance between that vessel and the cancer cells. And so we quantified the number of vessels in mouse pancreas cancer, human pancreas cancer, and we realized that there was only a quarter of the vessels in a pancreas tumor in a mouse compared to normal tissue, similar in the human. And Chris Iacobozio at Hopkins confirmed our data using a huge set of human samples. So again, different from the hallmarks of cancer where you think angiogenesis is a driver of cancer initiation and cancer progression or maintenance. In this disease, that may not be the case. And it may be true for other desmoplastic-rich tumors. And another thing, so there's less vessels in this tumor. And again, if you compare that just to colon cancer, it's about a 10-fold difference in vessel density. These are human samples. And the vessels that do exist are compressed by all that extracellular matrix, et cetera. So you can infuse lectins in a mouse, it will bind to the endothelial cell glycoproteins. Only a third are open in our mouse pancreas model. Probably similar is true in our human specimens. So a third are open, a quarter are present. You multiply fractions, the number keeps getting smaller. So less than 10% of the vascular density that you're used to in normal tissue exists in these tumors. And then, of course, there's a distance that any molecule or food or toxin has to go through in order to get from the blood vessel to the cancer cell. And it's 10 to 20 microns in a mouse, 30 to 40 in a human. And that distance is, again, through tenacious extracellular matrix, which could be another stumbling block. And so we thought this would be an attractive hypothesis for why we were having a difficulty treating these tumors with gemcitabine, as I mentioned. We stumbled upon a method to clean up the stroma, as it were, and that was using antagonists of the Hedgehog pathway. While we were doing these experiments, Fred de Sauvage at Genentech was doing similar experiments, and he showed that the pathway was active in the stroma of pancreas cancer, not in the cancer cells themselves. So in a paracrine manner, similar to development. And so when we used an antagonist of the Hedgehog signaling pathway, the stroma essentially went away over the span of a week to 10 days. And when the stroma went away, the blood vessels came back. And when the blood vessels came back, we could then do our experiment, our therapeutic intervention. We had to devise ways to measure gemcitabine triphosphate in tumor specimens, which hadn't previously been done. And with Duncan Jodrell's help, who's our resident pharmacologist and phase 1 doc in Cambridge, we realized 2 hours after administration, we could get the biggest peak of DFD-CTP, that's the active gemcitabine moiety, and that turned out to be exactly the time period that we had a wave of apoptosis that we could measure. And so we used that as our method for doing the PK and PD assays. When we did it, we could see that gemcitabine delivery was now increased, and importantly and relevantly, we now shifted the curve to the right in a survival experiment. And so the purple curve here is when you treat with the Hedgehog inhibitor plus gemcitabine, all the animals live longer. These are all the monotherapy curves. And so we thought we had our foot in the door to start some things with folks of the two-legged variety. So again, so as a brief synopsis of the first part, we think poor drug delivery is a primary problem in ductal pancreas cancer, and it's due to, again, the structure of the tumor. There aren't very many blood vessels. Those that are present are compressed, and there's that distance that things would have to travel from the vasculature. We stumbled upon one way to potentially alleviate that using inhibitors of the Hedgehog pathway. There probably are other ways of doing it also, and of course, being a physician, I wanted to translate this. The other method that we've used to actually get essentially the same bang for our buck was to use an enzyme that our nurses use in the chemo infusion room whenever the IV falls out of our patient's forearm, which is to inject hyaluronidase under the skin of your patient so that you loosen up the extracellular matrix in the skin, open up the lymphatics, drain the chemotherapy. This enzyme has been pegylated and is available for clinical use. And we've used it in our model. We're going to have the same sort of lighting issue right here. But in any case, this is a similar experiment to before where we're asking, can we perfuse small molecules into our tumor? And this is our control. You got a blue spot and a green spot down here. If we add this enzyme, again, into our animal, and this is tailed vein injection of hyaluronidase, within an hour, you can get small molecules into the tumor. You can get more gemcitabine triphosphate into the tumor. You can see the target go away in the tumor, and that's because you're popping open those blood vessels. So those compressed blood vessels are now popping open, and when they're popping open, you're delivering chemotherapy, and you get a very similar survival curve to what I showed you with the Hedgehog inhibitor. So a totally different mechanism that in the end effectively enables a similar delivery phenomenon to this tumor type. Now these mice at the end are dying with stable tumors, and they're dying with baggy hearts. So they actually are dying of end-stage cachexia and things like that. Totally fascinating. One of the problems our patients have, maybe this is a model that we can now dig into that problem too. Okay, so I claimed that I was a physician. So these are the folks that we work with in Addenbrooke's hospital. I'd say doing science on this side is not so different. Doing medicine is different, but doable. You know, it's just different. But I would invite Dr. Chabner and all my American colleagues who had all these questions for Peter Johnson to, come over and spend 6 months. You use a stethoscope and all the things that you're used to that were invented over here initially. But the way things are done is different. And so we had to assemble this team of people who are already busy. They don't need to be on your R01. You have to incentivize them to want to work with you on these problems. Now, we have great surgeons that we work with, terrific endoscopists, trained by Bill Brudke in your center at Mass General. And here's my one fellow. The problem is we don't have enough trainees. So we have like one medical oncology fellow. And I'll lose her to Princess Margaret pretty soon. Anyway, so here's our team. And we wanted to get together and translate some of the stuff I talked about. And so again, harkening back to one of the early presentations, I wanted to see what our biopsies looked like. And I can't remember who brought this up, but this is how we diagnose pancreas cancer. So this is obviously the Papa-Nicolau stain. These are red cells. Here's some, probably some polys. These are our atypical looking cells with a bit of schmutz in there. I mean, yeah, you could say there's typical looking cells, but you could never do anything properly scientific with such things. But that's from either a brushing or EUS FNA. With the same EUS needle, we can now get microcores, 22 gauge needle, not a new needle, not the new fancy needle that I've heard about. This is the same needle. Here's our cancer cells, here's the stroma. And this was about a 2-3 year project. And we now use these samples to do the trial I'm going to talk about. So here's that before. Cytology specimens, histology specimens. Same needle, no need for any cytologists. You save a lot of money, you save a lot of time, you get better diagnoses. Hopefully I can get some journal to agree with me soon. And this is what they look like now. And so now we can do immunohistochemistry, look at epithelial cell markers, various pathway activation markers. We have one trial I don't have time to talk about in the antagonizing the Notch pathway. And here's just a simple thing downstream of RAS. Why do we do this? Because we wanted to go and do that Hedgehog trial I talked to you about. So we can do actual laser capture on microcores from an EUS FNA 22 gauge needle. And here's some evidence for that. Here it is partially stained. Here we're first laser capturing the stromal cells, and then we come back to get the ductal cells. And why'd we do that? Because we were trying to quantify GLE1, which is the downstream transcription factor in the Hedgehog signaling pathway, and we can show in the stroma it's higher than in the epithelial cells. Stroma it's higher than the epithelial cells, 3-to-1 to 10-to-1. So now we can do the trial. And what's our trial? Our trial is to take patients going to surgery and to give them a Hedgehog inhibitor for the 2 weeks before when they sign up to get their operation and they get their operation, so that we can do a proof of concept window study, not really neoadjuvant, because I'm not trying to shrink the tumor, but actually I'm trying to learn if our hypothesis was correct. And our primary endpoint is safety, because there is a 1% to 2% mortality when you undergo Whipple. Pancreatic leak and other things can lead to this, and so we want to make sure we're not having more events. But our molecular endpoint is GLE1 expression changes. And so we started this trial with some financial support from Roche Genentech. We have a couple of patients on the trial now. It's a 20-patient trial. To me, it's the simplest possible design, and so that's why we're trying to move forward. Over in the States, my friends there have taken the same drug that we used in the mouse to give it to patients, and this is a trial headed up by Charlie Fuchs. He presented this at ASCO. In the first 16 patients that they treated with the IPI 926 from Infinity, they had 5 partial responses, a whole bunch of stable disease. This is probably their cherry-picked or green gauge-picked patient with a tremendous response. No information about survival, things like that. Promising, though. Okay, last part. Well, we always need to stick a needle in to figure out where we're going. What we do now is we take scans of patients using x-rays, not too high resolution. We don't even do 3D reconstructions. That's still a topic that for some reason we haven't been able to sort out as a community in any part of the world. So we use 2D reconstructs, looking for the biggest diameters when we decide is a patient stable or partially responding or partially progression. And of course, we'd like to do better. The simple approaches people have been doing, I saw some example of this morning using nuclear medicine type approaches, and for lack of better initial first ideas, we thought we'd do the same thing. And so you saw the spinning mouse before. That mouse got FDG ahead of time. And so we can see these tumors by FDG. And the question that I had was, is it the tumor? Because pancreas tumors, again, are fibrous, rich. They have a lot of inflammation. Maybe it's not the cancer cells. They're drinking the sugar. Maybe it's the immune cells, which, as you know, have activation of PI3 kinase, glucose transporters at their membrane. They drink sugar too. And so we were able to give a mouse FDG PET and then sacrifice the mouse immediately after the scan. And so here's the pancreas of the mouse. We sectioned the pancreas. The first picture was actually to expose it in an autoradiography type of way, such that we could get a heat map, and this is a positron emission, so it's hottest here and it's coldest out here. And then the same section we can fix and dip for H&E, and here it is there, and here's the blowup. And so where's the heat coming from? Is it coming from out here in Western Australia? The answer is no. So this is actually just PanIN. How about down here in, I don't want to say this wrong, New South Wales. So this is all fibrous tissue. But here where the heat is coming from is where the cancer cells exist in the stroma. So this looks to be a cancer cell specific hit. And that was important because then we were able to actually have our second trial. And so our second trial is totally simple, scientifically not too deep. It's just a question of if you gave a patient FDG PET and then treated them with gemcitabine and then got another FDG PET right away afterwards, could you predict the patients that ultimately are going to respond? 10% of patients given gem will have shrinkage. 30% to 40% will have so-called stabilized disease. Half will grow through. So it would be great if you could pick up the responders and the non-responders and then do something. Try to do second-line trials, et cetera, things like that, which we have no data, no chance in this disease. So that's the idea. We've done 10 patients so far, and our benevolent supporter has become less benevolent for this. But we have finished 10 patients, so we're going to actually analyze our data about that soon. So I tried to, in the 20 minutes we had together, tell you a little bit about pancreas cancer. There's 4 approaches that I favor going forward. Pharmacodynamically, combinations therapy with the gemcitabine, which is partially active in this disease, extremely active in cell culture, extremely active in subcutaneous xenografts, partially active in patients and in mice. Combinations with gemcitabine, RAS pathway inhibitors, other things. We're thinking about all of that now. But I think our work and other things I have no time to talk about has really reminded us that the pharmacology is extremely, extremely important. And I think that's the big difference between the xenograft and the primary pancreas cancer model here. It's the pharmacology. It's not anything else. It's not the other interesting scientific topics that we can easily get into. I think increasing the level of gemcitabine in the tumor is going to be extremely important, and there's probably a variety of ways of doing that. Biopsies. This has come up already. I'm going to say it the last time. We need serial biopsies for patients on trials so we can measure these things. Sometimes we'll figure out imaging ways to do it, but for now we really need those biopsies, and this is, of course, going to be a hard one for this disease. And then we need, so-called co-clinical trials, a term coined by Pier Paolo Pandolfi, but, essentially this is what most of us are doing anyway. Use good mouse models as you treat your patients, try to learn from both, because this terrible cartoon that Doug put together when we tried to do a review together is that if you have a mouse, this is actually a mouse with a tumor, not a helmet from some Gothic country. If you treat it with a drug where your idea is right, the tumor gets smaller and then you do a trial and the patient gets better and you write a paper. But reality is that the tumor responds partially and then the patient responds partially and the tumor comes back because the tumor is heterogeneous. It's not one clone, it's multiple clones. It's multiple clones and that's why we have trouble. I don't know if looking at 100 patients is better than looking 100 times better at one patient. I think that there's a lot of information we don't get from each patient. So I think if you use both, you'll do better than this guy. So this is my football joke. So Octopus Paul picked this country to win. He was right. He picked the right country 7 out of 8 times. That's much better than anything we have. Any algorithm, anything. But that's where we want to be at least as good as him. And so this is the team of folks who contributed the work. I thank you for your attention.
That was very nice talk. Bruce and I would agree that pharmacology is very important. Questions, please. Yes. Dennis.
I'm trying to understand, this tumor is like a brick. Is it very hypoxic? Does it become necrotic? Or are there very efficient cell-to-cell communications that allow, obviously, the cells to remain alive and viable?
So RAS mutant cells are probably the most resilient cancer cells that we know of. So that's one partial answer. Second point to make to you is that the proliferative rate of pancreas ductal adenocarcinoma cells, when a pathologist looks at them and compares it to a colon cancer where you have lots of blood vessels, not different. So the cells live in it. They're a cactus in the desert. Cactuses live in deserts. They don't live on our lawn, right? So there's obviously a coevolution of pathways and programs which are unusual about this cell type. So I think that they're able to deal with resource management and waste management in ways that other cells are not. So that's my, newspaper answer to you. How do they do it? It looks like they actually engulf food as one mechanism. They use macropinocytosis, and when they're glutamine hungry, they just nibble things from the extracellular matrix. And that extracellular matrix is alive. It's totally living. It's not cement that needs to be fixed next year. It's like actually turning over probably slightly more slowly than the inside of a cell. And so I actually think that the whole thing, although it's unusual looking and you would say, well, a priori, they should be hypoxic, at least unhappy cells, et cetera, et cetera. Again, there are many pathways and many processes which are distinct between the pancreas cancer cell and, say, the colon cancer cell. And thus, I think that offers us many basic science questions to ask that probably have therapeutic relevance. And we're just barely starting to do it now. The hypoxia experiment, for example, is happening in the operating theater in Canada right now. People are injecting in pimenidazole like drugs into patients to ask, are they hypoxic or not? They probably have a relative hypoxia, but they're not actually that necrotic as tumors. Nothing like melanoma or others, rapidly dividing.
Bruce?
Very proud. You make me very proud of our training program. What about the tumor that metastasizes? Does it preserve it's not in the same environment. Does it become vascular? Does it become less hypoxic? Is it easier to kill?
Yeah, great question. So what we know from the mouse experiment is the easiest way to find a MET into the liver is to inject the adriamycin that you guys weren't able to appreciate into a mouse and to look for the blue speckles in the liver, and that will be the 4 to 8 to 12 cell clusters that don't have any blood vessels in them. Now, when we look in our mouse, and when Chris looks at her autopsy specimens from pancreas cancer down in Baltimore, which she's done almost 100 now, we see there's two types of liver mets. One are very cystic, which with the cells essentially growing into the edges, with, again, a cystic cavity. The other are extremely similar to the primary pancreas tumors, which have a tremendous amount of stroma, et cetera. And the vascular density in those mets seems to be exactly the same to a primary. So there seem to be two patterns. But excellent point. When you talk to docs who actually take care of a lot of pancreas cancer patients, and you ask them, compared to Charlie's patient up there who had their liver mets all go away, does that happen very often in pancreas cancer in patients getting gemcitabine? In my experience, the answer is no. It's not colon cancer where you can see the mets and treat with full FOLFIRINOX and make the patient better. It's nothing like that. Occasionally you have big responders, but it's a very different disease. Yes.
One more question?
Nice talk, Dave. Quick question. I seem to see in one of your slides that the Hedgehog pathway is altered in pancreatic cancer, and you think that there is probably downregulation at the level of GLI1. Do you know what is the mechanism or the reason for that downregulation? Is it mutated? Is it hypermethylated?
So I went very rapidly through all the Hedgehog information. So again, the Hedgehog ligands, sonic Hedgehog being the main one, are produced by the neoplastic epithelial cells in the pancreas. They make the ligand. They produce the ligand, but the cell responding to them is in the stroma. So it binds again to patched on a stromal fibroblast, cancer-associated fibroblasts, myofibroblasts, has many names, activates the Hedgehog signaling pathway in that cell to mediate, again, the promotion of proliferation and secretion of multiple things, including collagen, by that cell type. GLI1 as a transcription factor in the pancreas cancer cell is activated by the TGF-beta pathway. That's something that was shown by Doug Hanahan in a real nice Genes and Dev paper. And there's lots of TGF-beta in a pancreas tumor, as you would predict. And yet the pathway is oftentimes mutated canonically by a SMAD4 mutation. So anyway, that's more information than you were looking for. The pathway is not mutated in a pancreas cancer cell like it is in medulloblastoma or basal cell carcinoma, nothing like that. So it's more of a paracrine interaction with the tumor microenvironment.
Thank you.